as we always do. So tonight it will be a HESI review. You guys are gonna start the HESI review with your games from last week. So we'll make sure that we have those, and then I'll go over some HESI stuff with you guys that I have. Just remember, HESI is a accumulation of everything that we've learned such up till this point. So anything is game. Please know that for our HESI for last HESI. The math was the biggest problem. So just remember that when you're studying, make sure you're good on your math, because that was really our students' problem last time. Any quick questions before we start the games that you guys did last week? No? Alrighty. All right, so let's start with group number the group on infertility. Where's your game? You're gonna share it with us, share the screen, and we're all gonna play the game with us. All right, so the fertility group was, let's see, Shalonda, Melissa, Mia, Amanda.
I'm looking for my information. I don't know where my other team members are.
All right, well, while you're gathering yours, let's do endometriosis. That was group number two. That was Tara, Jenny, Kelsey, and Emily.
I'm just pulling that up right now, our Kahoot.
Okay. Melissa, your camera's off, so I need your camera on. There you go. All right, well, Tara's doing hers. Everybody should be ready to go with this game, okay? So if I call on your group, then you guys should be ready to go. So you guys should have had this ready for class as we talked about last week.
I shared it in um the chat. Do you want me to share my screen?
Yeah, you can share. You're gonna host the game, so however you
Okay.
want to do it.
Okay. Um, okay.
So click host live, classic mode. All right, I don't think anyone joined yet, so I don't know who all these participants are.
Is there a join code?
Yeah, we need the code before.
The game, pin, I mean.
You can click OK Go and the number should pop up at the top. Oh, no. You have to host live and then it'll give you a login.
Okay. Where? I'm just gonna click out of that. Leave. Okay.
Emily said she got hers up if this doesn't work, so you have to log in.
I don't.
Yep, host live. Start. All right, here we go. Here's the pin. And you're gonna run the game. I'm not gonna say anything. You guys are running this game.
Okay.
So Tara's group, that should include Jenny, Kelsey, and Emily to help her.
Are people still joining?
You guys can.
Yeah. Just let me know when I should start, and I'll start it.
I would say just start it now. All right, so explain your questions for us, okay? So we're learning through you, so you're going to explain to us about your questions.
Okay. So a complete hysterectomy would be indicated for severe endometriosis. Um,
All right, tell us a little bit about what endometriosis is. And Tara, you're not on the hot seat. Anybody
okay.
can help you. Girls in that group, somebody help her out.
So,
What's about it?
so it's where the cells in the lining of the uterus grow outside of the uterus. So it can cause severe pain during menstruation, heavy bleeding, chronic pelvic pain. And it also, yeah. So it's basically like your uterine lining um, is outside of the uterus.
So was the answer to
Yeah.
that the progesterone cream or hysterectomy?
Um, I don't have my answer
So
key.
It's
it
going to be the
said,
hysterectomy. Progesterone cream, if anybody's familiar with pregnancy, which we all should be super, super uh, fluent with it now, they give that to keep a pregnancy, progesterone.
Right, I was just wondering because I selected hysterectomy and I think most people did, but then it said that green was the right answer, which was the
Oh,
progesterone
yeah. So
cream.
no, that would not be because
Okay.
progesterone cream you can use for fertility. Thank you
Okay,
for
just wanted to
clarity,
make sure.
Leticia.
Uh-huh.
Okay, go ahead. All right, so tell us about that question. Before you go ahead, before you guys keep going ahead, you need to explain each question to us, okay? Because we're learning through you.
Okay. Do you just want us to explain it like when the question is up or after?
Yeah, as opposed to going to after the score. So you can just explain it before you go to next.
Okay. So basically, endometriosis, before you get your period, is going to be more painful because of all the swelling and like the blood in your uterus or the lining coming out.
Okay, Jenny, you do the next question. Tara, just get it on the screen and Jenny's up. Okay, don't go to next. Jenny, explain this question for us.
I honestly don't know the answer to this one to even how to explain it.
All right, guys, the whole point of a game is so that you guys know the content and you're able to teach your classmates. So I'm a little confused with this group right now because we're not really having an ability to explain the answers. So try the next question and see. All three of you should be contributing. Kelsey, I presume, is not here. Is that correct? So somebody should be able to answer these questions and explain it to your classmates. That's the whole purpose in the game, is so that you guys learn from each other.
I'm not sure that any of us were really clear on the instructions. I thought we were creating the game and then we were all going to go over it together. I didn't know that any of us were going to be doing the teaching.
Okay, but if you made up questions, how did you guys come up with questions? Right? If you made up the questions, then you guys should know the content of the questions, right? How else would you come up with questions? Does another group, is there any group that's comfortable in teaching their game? Is there anybody who has created a game that they feel comfortable with sharing their game and going over the content? Okay, so I'm getting a no on that one. All right, then we won't do the game for our HESI review. That's fine. What we will do though is we will do a HESI review. And you guys should be really much more comfortable with this content that you guys studied, okay? So I'm a little concerned because this is last week's content. So hopefully you guys did some reading like you were supposed to for last week. I'm not just saying this group, but the whole class is general. It's making me a little uncomfortable if you guys aren't familiar with this material. But it's okay. We're gonna move on. So Tara, you can stop sharing your screen and then we'll do our HESI review traditionally, and that way you guys can go over the content and then it's not on each of you guys to do that. So let me just pull up our HESI review. Like I said, please make sure that you guys have your math skills down because that's very important for this upcoming exam. And so on your announcements, we got an email from one of the deans saying that none of the classes were doing HESI reviews. So I'm a little confused where that came from, but that's okay. I'm just going to show you where you can find all the HESI reviews. There's several of them. And so you can go to any one that you'd like. Here's the list. It's under announcements and it's called HESI Study Schedule Week 10. So we're already on Wednesday, but we had some on Monday, we have some on Wednesday, and we'll have some on Friday as well. Okay? So they'll be taped and they'll be posted for you. So make sure you're following those and going to different HESI reviews because that's very important for this for you guys to review content. The content that'll be covered on your HESI is everything that has been covered in the OB readings and chapters. So make sure that you are comfortable with all of the reading that we have done throughout the quarter. Your exams were some information that was helpful. So whatever was on your exam is always good to review. You also want to, there's a ton of HESI study materials and resources. So I'm going to show you that. We're going to go over one of them, but I just want to show you where that is because you guys have a ton of resources for HESI to look at. So this is where it's going to be. This is under announcements. Here's your prepping for HESI. Here's your content. So you have content, you have a review, you have another review, you have OB meds and OB crossword puzzle. You also have some HESI review and math tutorials. Here is where I would go over all of these calculations. Make sure that you're familiar with potassium, magnesium, heparin, and multi-step math. So that'll be that's given under your HESI resources and studies. And then we tell you to review your NCLEX. There's some OB practice questions and some games. So there's a ton of games here. There's Kahoots and Jeopardy and all that if you want to do that. Okay, so we're going to take a look at our HESI key topics. And I can't emphasize enough with you guys that you really have to have your math down pat. So we'll cover that. But let's take a look at our HESI main topics and see what that looks like as you go along. Okay, so we start off with a review of what we started our class with fetal development and testing, right? So we remember that when we're doing fetal development testing, we look at genetics. Remember, we have 46 chromosomes that we look at. We do blood work to get our normal chromosomes. Fetal development, there's different stages. We want to know about fetal circulation, which we spent a lot of time on. Where does our placenta help? Amniocentesis is a procedure that we can do to determine lung maturity. And when you do an amniocentesis, what are you taking out of the belly? Or do you think you're taking
Fluid.
amniocentesis?
Amniotic fluid.
Fluid.
Good, amniotic fluid. And so with that, you can then test it for different things. Our alpha fetoproteins, that's our blood work that'll be elevated with our neural tube defects, spina bifida, and that kind of stuff. All right, GTPAL, we went over this and you had this on a quiz. Remember gravity and parity. Gravity is how many times pregnant, parity is how many do you have. So just remember as we look at this, you could have a G1T2 if you have twins, you could have a G1T3 if you had triplets. We're looking at what happens during pregnancy. So we have an increased blood volume, we have possible anemia. What group of students is going to be I'm sorry, what group of patients is going to be most likely to have anemia?
Pregnant?
Well, of course, all our patients in this chapter in this class are pregnant, right? But who's going to
Is
be
sickle cell,
hmm?
Hispanic, African American.
African Americans with sickle cell?
Okay, sickle cell. Yep. Our young pregnant people are going to be very highly concerned about anemia. So we look at these different things to see what how we figure out the due date, right? We do the first day of the last menstrual period, subtract 3 months, and add 7 days. Okay, nutrition and exercise. Exercise, we spoke about how important that is. It keeps the cardiovascular system working, right? Swimming, cycling, um, iron-rich foods. What does iron supplements do to the GI tract?
Slows it down, so
Constipation.
constipation.
Good. So those are down, so you're gonna have a lot of constipation. Poor intake can lead to
Iron
preeclampsia with our
deficiency.
anemic pregnant people. Weight gain, heartburn, which is normal. Adolescent, we spoke about increased risk of anemia, IUGR. So we're going to watch their weight and nutritional values. Here's some lab visits. These are lab works we're going to do on every patient when we have a prenatal visit. We're going to do an HIV first and third trimester. We're going to do a rubella, a Hep B, a VDRL, RH, CBC, and vaginal culture. We're going to do fetal assessment. So, what should our fetal heart tones be? What's our value for fetal heart tones?
110 to 160.
Good. And then a physical exam, we're going to check their weight. We're going to check their urine for protein. UTIs are very common in the last trimester. And why do we need to treat a UTI?
It could cause early labor.
Good. It causes preterm labor. All right, fundal height, which is important, is measurement of the uterus above this sympus pubis. So it's going to be same as or plus or minus 2 gestational weeks. So if they're 20 weeks, how many centimeters is that going to be on their belly?
20 centimeters. Sorry, either 2 centimeters above or 2 centimeters below.
Or, yep, so it'd be 18 to 22, right?
Yeah.
We know partner violence is increased during pregnancy. We teach them about prenatal classes. Like a doula, a birth plan, breastfeeding. Remember, we're breastfeeding as soon as they deliver. Fetal well-being, our daily kick counts. This should be taught to our patients that you get 10 in 2 hours. Usually from 18 to 20 weeks is when it starts. And if we don't get those fetal heart rates, daily kicks, they're going to come in for a non-stress test to see what the heart rate looks like. All right, ultrasound is a non-invasive test that checks out fetal age, is everything okay, all the body systems. We have contraction stress tests to see how well the fetus tolerates that. Substance abuse and STDs, we talked about smoking, illicit drugs, alcohol, withdrawal, HIV, and herpes. Remember, with smoking, what do we know about these babies?
They're smaller.
Yep, they're usually smaller. The respiratory systems be compromised if they're living among cigarette smoking. So we're going to encourage smoking outside. Does anyone know what else we encourage when people are smoking around little babies?
To not do it around them because of like secondhand smoke.
Right, and actually the clothing that they wear is harmful. So teach those parents to change their clothing. I mean, whether they do it or not is one thing. All right, our withdrawal, we spent a lot of time doing withdrawals with our babies, so we know that. HIV, you know you're gonna be running those antivirals and then checking the baby. How long do you check that baby for HIV exposure? If mom is positive, does anyone know? Or even if mom's not positive, how long can it present itself? For 1 year, okay? So for 1 year, we're gonna be watching them. All right, congenital abnormalities. We talked about a lot of these. Down syndrome, spina bifida. What do you get spina bifida from not having enough of? It starts with an F.
Acid.
Folic acid
Good. Folic acid. Where do we find folic acid?
in the iron.
No, not in iron. Where are you going to find folic acid?
For like orange juice and stuff like that.
Okay, whatever is supplemented with folic acid, you can always see that. There's cereals, there's lots of things. All our prenatal vitamins have that folic acid in them, so make sure we're encouraging that. All right, we talked about torch. I don't know which week, but those viral agents with manifestations that can occur in the babies. So we have those like toxoplasmosis, rubella, CMV, herpes simplex. So we're gonna make sure we isolate that baby if she or she or him is exposed, right? Labor and birth, we talked about this for a whole week. So five P's. What are our five P's?
Pallor,
Center.
No, five P's of labor and delivery. Five things that are gonna impact how that labor and birth goes.
Isn't that like the
Pathway.
passenger
Good. Yeah,
It's like
passenger. What else?
passageway,
power,
powers,
position,
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 and
power, psyche. What
psyche?
else? One more.
Passenger,
Passenger,
passageway,
passageway,
powers.
power, position, and psyche.
Good. All right. Signs of early labor. We can have contractions. What makes it true labor versus false labor?
Dilation.
Yep. Cervical dilation. Onset of labor, we're going to have some hormone changes. So when we spontaneously rupture membranes, which is SROM, we're going to look at color, odor, amount, and effect. Meconium stained fluid. What do we worry about with those babies?
Respiratory distress.
Yeah, because if they suck it in. We have different stages of labor, first, second, third, and fourth, and you guys did some work on those different stages. What are some delivery outside of the hospital considerations? What are some things we should worry about?
If there's like an emergency, they don't have access to emergent care.
Good, like what?
Like the NICU? I don't know.
Yeah, so what if they don't have oxygen? What else?
If the
Um,
placenta detaches too soon, so hemorrhaging for the mom.
Yeah, you could have hemorrhaging, postpartum hemorrhage for sure. Or what if the placenta separates? You're not gonna have
Yeah,
anybody to help you there. Good. What are some other things that we worry about? What are some problems that can occur?
baby
umbilical
getting
cord
stuck.
problems. Sorry.
Yeah, umbilical cord problems. The baby could get stuck. All these kinds of things. Good. So just think about that when you're teaching about delivering in or out of a hospital. Okay, signs of early labor. We know we talked about maternal comfort, pain control, deep breathing, how you can do some epidurals. Remember, those post-epidural headaches are pretty important. Usually that means it's gotten into the spinal fluid. Um, what happens post-epidural to your blood pressure?
It can lower
Hypotension.
pressure.
What happens?
It can lower the blood pressure.
Yeah, it lowers the blood pressure. So what do? The blood pressure is going down. Post epidural. What should you do to the patient?
Lay them on their left side.
You always go on the left side. Good. And what else?
Fluids.
Yeah, fluids to up their fluid content to up get that blood pressure up.
And
All right, what affects fetal oxygenation? Lots of different things. Fetal monitoring. We talked about accelerations, how we should be seeing those, and decelerations. What are some reasons for them? Variable. So it's the veal chop that we talked about. Variable decelerations is cord compression. E is early decelerations, and that's just head compression. Accelerations means they're A-OK, and late decelerations are not good because it's placental insufficiency. Variability is how squiggly the lines are at baseline. So if you look here, it's a pretty straight line. You don't have any variability here. Here you have some more variability, ups and down. Anywhere from 6 to 25 beats, right, is going to give you a good variability. Minimal variability again here if you look at it. So here's another one that's important. Another example. Everybody see how this is like a straight line?
Yeah.
That's going to be minimal. And then moderate, you get some squiggles. And then when you got big squiggles where it's a difference between 25 beats per minute. So if you go from 160 to 110, 160 to 110, that's too much variability. So that can have a lot of narrow impacts on the baby. All right, accelerations and decelerations. We talked about head compression. Are these bad or good when you have head compression?
Bad.
Why?
The baby's not getting like proper oxygenation.
No, the baby's getting fine. Their head's getting squished. So early decelerations we don't worry about. What that means is the baby's head is coming down in the birth canal and it's getting squished. Variable means that there's something with the cord. Okay? So variable is we're not sure if they're good or bad. So here's some things that we do when we have those variable or late decels. Okay, we're gonna stop the Pitocin possibly, go to the left side, give O2, give a bolus. And if you're over contracting and that's why you're having fetal heart rate problems, you're going to stop those contractions. So it's called the lion mnemonic, left lateral side, increase IV fluids and oxygen by 10 liters if it's a late deceleration. All right, contractions we know are monitored on an external monitor or an internal monitor. So the way we count them is from the beginning of one line to the beginning of the next. So you guys did this in class. So remember you start from the beginning of one. So 1, 2, 3. So they're 3 minutes apart. And then 1, 2, they're just about 2.5 minutes apart. So 2 to 3 minutes apart you would chart on that one. All right, C-section and birth. All right, pre-op, we hope that they're NPO, but sometimes if it's emergent, there's nothing we can do about it. Why do we want them NPO for 8 hours?
To avoid the bronchoaspiration during the intubation, you need to do intubation.
Yep, if you have to do intubation, very good. What kind of labs are we going to draw for a C-section?
Coagulation, so PTT on PTT.
Maybe. Only if we have something wrong would we. What are we generally going to draw?
Cross and type.
Good, cross and type in case they need blood. What else?
Complete blood count on
Yeah, a CBC. You're going to do a CBC and a type and cross because you want to see where's their hemoglobin, where's their hematocrit before you cut them open, right?
Yeah.
Okay, what about hair? You're going to shave that away? You're going to put
Yes.
Foley in because they're going to be numb? And then what is different postpartum for a post-op assessment?
The
You have to check the incision.
Okay, you're going to check the incision. What else?
make sure they don't have the debris. That's one.
The what?
debris. I don't know how it's pronounced. The debris, to make sure the surgery, I don't know what's the name. They don't debrief the C-section. Is that?
Oh, that I see what you're saying. That the wound doesn't open?
Uh-huh.
Yeah, you're gonna do that. That's true. You're not gonna do a vaginal assessment, are you, on a postpartum C-section patient? No.
You're going to
Because I haven't
check
done
the
anything to the
fundal
vaginal
height.
area. Hmm?
Check the fundal height.
Yeah, you're always gonna do that, but that's O on any postpartum. So they're asking what's different about the cesarean. Remember, it's surgery, so what are we gonna worry about?
The
Vital signs.
lungs.
Lungs, vital
Infection.
signs, what else?
Infection.
Infection, did they have a
Fever.
antibiotics pre-op, which they should have? Okay, is the Foley draining? Because they're gonna be numb, remember, so you have to make sure
Mhm.
bladder's draining. So
Yeah.
all of these things. All right, we look a little bit at postpartum assessments. There's so many mnemonics that I'm gonna skip that one. Postpartum health promotion, we're gonna make sure we give rubella if RH is a concern. I'm sorry, not rubella if they don't have the vaccine. Rogam for the if they're RH positive or RH negative. We're gonna know about breastfeeding and what's important about that. Here's some things to remember. Oxytocin has the letdown in our breastfeeding. Prolactin, and it has the word lactin, like lactose, helps form the milk. Colostrum is going to mature to milk in about 3 to 4 days. If not breastfeeding, do not stimulate the breasts. Engorgement and mastitis. What should we do for engorgement?
Continue to breastfeed every 2 to 3 hours.
Yep, you want to empty them out. Engorgement means they're too big, right? They're too swollen. All right, so you're going to promote breastfeeding as a nurse, but you're not going to be unkind at all. All right, when we look at that uterus, involution, inversion at knee. Remember, now should it be firm or boggy?
Firm.
Okay, so how do you make it firm if it's not?
Massage it.
Good. And what else? What medicine do you give?
Oxytocin.
Oxytocin,
Yeah.
yep. You're going to give that to right after they deliver to firm it up, right? Fundal height and position, what affects it? What is the action? What if it's to the left side?
Tell them to urinate.
You can tell them, but they probably won't be able to if they're numb.
Or
So you'll do a
cath.
straight cath, yep.
Yeah.
What else can happen? What if the fundal height keeps going up and up and up? What do you think that might mean? Instead of down, it goes up.
Hemorrhage.
Yeah, it could be filling up with blood, right? So if that's the case, then we're going to make sure we um, draw some labs on them, let the doctor know. Are we seeing any bleeding coming out of the vaginal area if they had a vaginal one, if they had a C-section? You should still see that because you're going to see, you don't need to assess the vaginal area because they haven't had any trauma to that, but you do need to always assess that rubra that's coming out. All right, postpartum, we talked about rubra serosa and alba. Excessive bleeding could be a retained placenta. Lacerations and hematomas are the second cause of postpartum hemorrhage. Why do you think you get lacerations and hematomas?
Just the trauma of birth, no?
Yeah, the trauma of birth
Pushing.
where? Yep. Where are you going to see lacerations and hematomas? What kind of patients?
The vaginal birth.
Yeah, those that gave vaginal birth. Very good, because that's where they're going to have tear or they're going to have swelling, right? Hematomas there. You can have a cervical laceration also if you have that bleeding that doesn't stop. That's our clue that it's a cervical laceration. Okay, we talked about uterine atony and what to do for it. Here's some other meds you can give other than oxytocin. You can give methergine, hemabate, and Cytotec, but these all are given sometimes. It depends on why we're giving it, but if we need to get them to contract for any reason, think about using any of these. So Cytotec and oxytocin are going to be used for inducing labor too. Retained placenta we talked about. That could be hemorrhagic shock. We need to make sure we restore circulating blood products. What are the signs and symptoms of shock in anybody?
Pale, clammy,
Good. They're pouring blood out, so they're going into shock here. So what are you going to see with that blood pressure?
low,
Yep. And then when the blood pressure goes high, the heart tries to compensate, so it goes.
low, or high.
Heart rate goes up as the blood
Oh.
pressure tries to compensate because it's low. All right, DIC, which we talked about, is a condition where it's severe bleeding. So you're going to see bleeding all throughout the body. You'll see it out of the mouth, out of the nose, anywhere that you can get blood out of, you're going to see it. So that's one that's really dangerous. It's life-threatening. Here's some hemorrhagic disorders, placenta previa. Remember, we know that our previas are going to be those painless bleeders, right? So what happens is that placenta goes over the top of the Oz. And for abruption, it's going to be painful. It's going to be hard, right? For the baby, hard for the uterus. What's going to happen for the baby? What do you think you're going to see with these? You're having bleeding because the placenta isn't working great. They're still in utero. What's going to happen to them?
Their heart rate's gonna drop.
They're
Yeah,
gonna show signs of distress.
Yep, you're gonna see signs of distress. Good. Let's see here. Regardless what kind, but I need you to remember painless is going to be that previa where it's over the Oz, and abruption, when it actually abrupts, you're going to have painful. All right, we have some conditions that are the three big ones: diabetes, hypertension. And what do we know about diabetes? There's people that have diabetes before they get pregnant and people that get it gestational. Okay. There's risks to the fetal and maternal. What are some risks for our fetuses?
They're bigger.
They're bigger if they're gestational. What else?
Don't they have like heart deformities, like
Good.
cardiac problems?
Cardiac. Yep. What are diabetics higher risk for?
Macrostomach babies.
Yeah, we
Preeclampsia.
said that bigger ones. Yep. Or preeclampsia. So we're going to look at those. Then we have those patients that are hypertensive, right? Could be gestational, could be chronic. And then we have preeclampsia, which is going to be our vasospasms, okay? It is suggestive. Its diagnostic criteria is high blood pressure and another symptom. So we might have protein in their urine. We might have impaired liver function. Might have cerebral or visual symptoms. You're going to have swelling, those increased tendon reflexes. Proteinuria, we said. Headache not resolved by Tylenol. All right, treatment for preeclampsia and eclampsia. Remind me what eclampsia is.
Seizure.
Good. Seizures due to this high blood pressure and whatever other symptoms. So we're going to treat with magnesium sulfate. It says know how to calculate. So it'll be a 6-gram load and then a 4-gram maintenance is usually how it is. We're gonna see flushing, sweating, decreased uterine tone when we have this. Babies get tired from magnesium. So we're gonna always be assessing urine output, deep tendon reflexes, respiratory, lung sounds, and epigastric pain. Why do we care about epigastric pain?
For HELP syndrome.
Good. And remember what is in HELP syndrome that would give us epigastric pain?
Elevated liver enzymes.
Our liver is shutting down. Okay. So anything for eclampsia, we're going to think airway. So remember, in any of these questions that are where we're worried about it, we're going to be looking for airway, breathing, and circulation. All right. Preterm labor, uterine tightening. We give suppression of uterine activity. We administer betamethasone for our lungs to prevent our rate of RDS, which is our respiratory distress syndrome. And we know that preterm labor is what causes the largest number of admissions to NICU. Sometimes we have that premature rupture of membranes and choreo, and premature is when the membranes rupture before they're planned to. Okay, so you get infection, the more open that balloon is, otherwise known as uterus, the more likely it is to get infected. And then you can always have a cord prolapse, of course, where the cord comes out. And you have to do what if you have a cord prolapse?
Reposition the
Mhm.
mother. And
You're going to
sometimes
be
you have to hold
very
it in
specific
place.
about this. What are you going to do?
Knees
Knee
and chest
chest,
Good. Why are we putting in a knee chest?
to take the
cord.
babies off the cord, like to
Exactly.
take pressure, move pressure away from the cord.
Yep. And sometimes what we'll do if we don't do that is remember you're going to hold the cord in between your two fingers to make sure that it's still open. Okay. So there's nothing going back and forth. All right. Choreo, we've talked about multiple times. That's when the amniotic fluid, there's an infection in there. So usually you'll see mom having a fever. You'll see the baby and mom getting tachycardic. We're going to do antibiotics. Our dysfunctional labor, dystocia, that means when either it's too fast or too slow. And oftentimes we use oxytocin with our inductions and augmentation of labor. We use Cytotec and oxytocin. Most commonly, why do you think oxytocin is one of the safer ones to use?
Because our body makes it.
Okay. I want you to think about how it's administered.
Uh,
How's oxytocin administered?
Intravenously.
Good. So, how is Cytotec administered?
I believe either you can take it oral or they can put it or by your cervix.
Good. And how about prostaglandin gel? How's that administered?
Um, by the cervix or on the
Okay.
cervix.
So, which of the three can I stop?
Okay, yeah, I see what you're saying. Oxytocin.
Why can I stop oxytocin and not Cytotec or gel?
Because it's hard to just get the gel back or the pill dissolves and so is the gel, kind of.
Yeah, they both dissolve. There's no
Yeah.
getting them back once they're in the system. Oxytocin comes by IV, so you can stop it. Right? Does that make sense to everyone? That's why it's going to be a safer use. How do we use safely? Do we just keep upping it? Or how often do we up Pitocin?
Oh. Would it be doctor's order? I don't know.
Yes, it's of course you need a doctor's order because it's a med, but be
Would it
very
be
careful.
based
How
off of
often are we going to increase it?
would it be based off of the progression?
Mm-mm. No, but that's
No.
interesting. Well, sometimes you can stop
Her
increasing it.
vital, her
I'm sorry.
vitals.
Every 30 minutes, guys, you're going to up it every 30 minutes, as long as what things have to be happening in order to increase the Pitocin.
Labor has to be progressing.
Well, it
The
may not
cervix,
be progressing, but that's why we're giving him oxytocin.
right, but the cervix needs to be opening.
Mm,
Would it be the effacement?
No, I want you
No,
to think
like
about
the
where are we going to give medication to make them have more contractions and stronger ones?
if you're
For
contracting and trying to
vitals?
work the baby down.
Okay, but what in order to give this something to make more contractions, what do we have to have with our contraction pattern?
It's dilation, right?
Nope, that's what your
No?
classmate said. Mm-mm. You
Oh,
usually give
sorry.
Pitocin to help with it, the dilation, correct? But in order to give oxytocin, you have to have a reassuring fetal heart rate, and you can't have too much contractions happening. You need to have a break in between contractions, right? Those are your two things before you give anything to help with the contractions, right? You have to make sure the baby's okay and the uterus is okay. So you don't blow out the uterus, is what it's called. Because if you contract without a break, it's gonna give out. All right, vacuum assisted birth, forceps. What are some risks for forceps?
Hematoma.
You're gonna get that more with a vacuum, but good. You can get a hematoma in a vacuum because remember you're sucking the head out. The forceps is a piece of metal and you're pulling the head out. What do you think can happen?
Cut my baby. My baby's head.
Yeah, you could hurt the baby's head, putting a piece of metal on it and pulling it out. John Travolta, if you ever read his story about forceps, he'll tell you he still has a mark on his head. Vacuum assisted birth, remember if it pops off too many times and you stop using it, because how many times can you suck on a baby's head without having some sort of bleeding or trauma to the head? All right, OB emergency, shoulder dystocia. Why do we get these shoulder dystocia?
Big baby or the passageway is not anatomically, or it's too small.
Good. So what ends up happening is the head comes out and then the shoulder gets stuck. What do we do?
I know there's two different maneuvers, but I forgot the names of them.
Yep, you're right. Two different maneuvers. One, you pull back and then push out, and one you push right above the shoulder. But what ends up happening a lot of times with these shoulder dystocias with the babies?
Oh, they get a broken clavicle.
Yep. So you're going to see that broken clavicle, or you're going to see some of their reflexes not as good or uneven on both sides. All right, cord prolapse, we talked about this. And a amniotic fluid emboli is when you can have an emboli disperse and it goes to the lungs. VTEs, we have a high incident in the first 3 weeks. So what do? We watch for those, right? Watching our labs and things like that. Postpartum infection, fever greater than 100.4 times 2 days. Wound infection, remember Rita? That was one of our words. Endometriosis is the most common. Endometriosis is most common, and that's an infection of the endometrium. And so we see that's very common, so we treat that with antibiotics. We're moving a little bit towards mood disorders. What do we know about um what do we about mood disorders?
Like the baby blues and postpartum depression and that.
Yep. Baby blues is when it goes away within a couple weeks.
Mm-hmm.
Depression is when it goes on for a little while long, and postpartum psychosis is really bizarre, hallucinating. This is those people that you hear about who hurt their children, hurt their babies. All right, newborn transition to extrauterine life. Remember, we think about a respiratory system, cardiovascular system, because those pathways are different now because they have lungs. Thermoregulation, we talked about that. Heat loss, where we change the blankets, give them a warmer, keep them away from the window. Remember, cold stress can lead them to hypoglycemia, right? Newborn stools, we've talked about that. Newborn immunity. We up until this point, they're immune because they're in utero. Greatest risk for infection is prematurity. And breast milk is really important because it gives us those antimicrobial factors. Their skin, they're going to have that gooey white stuff on it. Acyanosis, which means what?
Blue hands and feet.
Good.
And
Mongolian
pink
spots.
body.
Remember those dark spots that we see? They look like bruises, but they're not. Skeletal, you could have some molding where it's just like swollen from the head being pushed out of the vaginal area, and different complications. The fontanelles, we're always going to make sure we know where those are. When we do our newborn assessment, we give APGAR scores, right? That's appearance, pulse, grimace, um, activity, and respiration. You're usually going to get a 9. Why do you usually get a 9 on your APGARs?
Usually most babies have the acrocyanosis.
Good. So they're going to be bluish. So they get 1 instead of 2 there. Risk, first 2 hours, vigorous drying and stimulation. We may suction, ventilate with positive pressure. We're going to take a look at the cord. How many vessels should it have?
3, 2 arteries, 1 vein.
Good. Vital signs, we know what their normal range should be. Temperature should be within normal range. What could abnormal temperature or respiratory rate mean?
You need to take a glucose.
Good. What's going to happen with the glucose?
It's gonna
Oh.
be low.
If the glucose is low, what's going to happen to their respiratory rate?
Does it increase?
Yep, respiratory rate is going to increase. Any abnormal findings, you're always going to check a sugar. What else? Newborn reflexes, we spent time on that in class, so I'm not going to do a ton of them. Discharge teaching, you guys did some teaching plans, so you're pretty familiar with that. High-risk newborn, birth trauma, like we talked about, clavicle, skull, Brachus injury, Erb's palsy, so make sure you know about that. Neonatal infection or sepsis. What are some symptoms we're going to see with sepsis in a newborn?
Fever?
Yeah, fever. What else is going to be elevated?
Heart rate?
Possibly if they have a fever, yeah. What else?
Their respiratory rate?
Maybe. How about their CBCs? What's going to be elevated in their
Oh, the white blood cells.
Yeah, white blood cells because they're showing infection. All right, we talked about drug-exposed infants, and infants of diabetic moms, or post-term infants, complications of pre-birth, and the high-risk newborn. All right, newborn nutrition formula versus breast milk. Breast milk has anti-infectives, antimicrobials. There's a breastfeeding benefit. Anybody know what the breastfeeding benefit is other than anti-infective and antimicrobial?
Is it bonding?
Good, bonding,
Okay.
exactly. What are some breastfeeding cues? Baby will cry, the baby will turn its face with its reflex towards eating. We watch to help make sure they're getting enough. How do we know if they're getting enough? How do you know
Wet
baby's getting
diapers?
enough food?
Amount
Wet
of wet
diapers, what
diapers?
else?
Six,
Wet diapers and what else?
Weight,
Weight, they're gaining weight.
whether they're cranky or not.
Yeah, they're pooping, they're peeing, they're not yellow, right? Because their bilirubins are up. We know sometimes that antibiotics on a mom can cause thrush in the newborn. That'll be on the tongue, so don't freak about that. Fetal loss and neonatal death. This was a topic you guys did a game on, but it doesn't seem like the games were really great for us. So just know that we need the same medical considerations. What's probably important for these patients, should they be on a postpartum floor?
Ideally not.
Ideally not. You want to put them on a med surge floor so they don't have to be surrounded by all these moms with their new babies who are crying and all that stuff, okay? So we want to be sensitive to know that. Medications, here's a list of the ones you guys should know. Oxytocin, we talked about that. 20 units per 20,000 milliunits. Mag sulfate is on page 426. Calcium gluconate, which is our antidote for mag sulfate. Terbutaline, which stops the contractions, can cause tachycardia. And betamethasone is what we give for our babies, but it does increase blood sugars. So if we have a mom with diabetes, we're going to be careful about that. And hydralazine, which is a vasodilator for hypertension. Labetalol, something we can use for hypertension. Insulin, we know we use that for diabetics. Methotrexate is going to be for our tubal ectopics. RH negative moms with RH positive babies, they're gonna get their RH globulin. Methadone, who's we giving that to? Methadone is going to our what kind of people?
Drug abuse.
Yeah, drug users. Rubella, make sure we give that vaccine if they're non-immune. Here's a math calculation. So if we look at this for Pitocin at 2 millunits per minute, and it's available in 10 units per 500 mLs. So I would ask you to go over this calculation. I do my calculations a little different than this, so I'm gonna not show you my way because this is how you guys were taught. So it's X mLs per hour equals, and then you have to round it out so that you're left with mLs per hour. So every unit should cross out. And so minutes should cross out with minutes, milliunits should cross out with milliunits so that you're left with just mLs per hour. Okay. Mag sulfate, if it's given a bolus of 2 grams over 30 minutes, followed by 1 gram per hour, it's available in 40 grams. How do you set the pump? So review this one as well. Oops. Okay, and then we have Hesse Cahoots. So we will do one Kahoot together. The rest I would like you guys to practice on your own. Do you have any questions about what we've covered up until this point? No, we pretty much covered all content that we've covered all class, right? So let's play a Kahoot and then that will be about it for our Hesse review. Please make sure you're scheduled. Is everyone scheduled for their Hesse review? You should be. All right, so we're gonna do Hesse Kahoot. This is one of the Kahoots that you guys have available to you, so please use them.
Julian, I'll get ready. I can take you to the hospital. I'm gonna log off right now. You don't wanna go to the hospital? Huh?
Somebody's
You
on
do?
mute talking to their person about going to a hospital.
Sorry, that's my child. I need to take him to the ER.
Okay. All right, here's your pen for the Kahoot. We'll play it together. All right, so if you're not able to join because reached our limit, then that's fine. But here you go. Here's your first question. First question is going to be preeclamptic on magnesium. If urinary output drops to 20 mLs per hour, which intervention should the nurse implement? All right, 2 and 4. I understand why you would say 4. Before you notify that healthcare provider, you need to discontinue the mag. Why? How many mLs per hour should we be having?
There,
Good, 30 mLs per hour. So we know what's being impacted if they're having no output.
their kidneys.
Good, kidneys are being impacted, right? So something we need to think about there. All right, next one. When listening to the fetal heart rate at 12 weeks, the nurse would use which of the following? Twelve weeks, remember. All right, so oh no, we're not going to use a fetoscope at 12 weeks. The baby's not going to be there at 12 weeks. Remember, we only use a Doppler for these little ones at this point. Why do you think you use a Doppler at 12 weeks? Given our choices.
They're basically just the heart rate, like the heart.
Yeah, and none of those other tools would work at this point.
Yeah.
Okay. Remember, 12 weeks, they're tiny little, not even beings yet, right? All right, the nurse assesses the postpartum vaginal discharge on 4 clients. Which would notify, which would warrant notification to the MD? All right, of the 6 people who answered, somebody explain that question to us, please. Why is that the correct answer?
Because
That
it
means
should
they
it should start getting lighter, not go back to getting dark.
Okay, but it didn't say anything about dark. Oh, well, dark, okay, dark is one of them. But what does bright red mean?
Fresh bleeding?
And active bleeding.
Yep, active
a
bleeding. Good.
fresh
So you shouldn't be seeing that 5 days after delivery, okay? Deliver client has a temp of 101.4, tender says uterus large and not descending. What are we going to do next? Okay, I'm curious to the 5 people that answered urine, why would we assess their urine?
For a UTI? I don't know. Or sometimes if they
Remember, the
don't,
client is delivered, so are we that worried about a UTI?
maybe not.
The uterus is tender, so it's sore to the touch. It's large. It's not descending. What are we thinking?
Maybe urine retention?
If it was urine retention, where would the uterus lay?
Oh, to the right.
Or to the left, at least to the
Yeah.
side.
Yeah.
But what do we know? As soon as our uterus is tender and large, what are we thinking in our heads?
Endometritis.
Or a bleed, an internal bleed, aren't we? The uterus is getting bigger and is sore to the touch. So there could be some sort of bleeding going on there, right?
Mm-hmm.
Okay, what could cause bleeding after delivery?
A hemorrhage.
Inside, yes. And why are we going to get a hemorrhage inside the uterus?
Retained placenta?
Yeah, good. Don't you always sound like you're guessing. You're right.
Okay.
All right, let's look at our next one here. What is the nurse's initial action when umbilical cord prolapse occurs? You guys should all get this one. Very good. You're gonna need chest. What's your second action gonna be? Given
Turn
Call
your
for
around
help.
chest.
with a saline gauze.
No, absolutely not,
Not
because
notify the
Wouldn't it be
provider.
like a rapid response, like call for help and get
yeah,
patient into
yeah, it's
surgery?
an emergent, and you got to deliver quickly. Why? Because the cord is out. So that means the baby's not getting any of its circulation, right? So it's an immediate. All right, which of the following marks the criteria for postpartum hemorrhage? Good. More than 500 cc's is going to be a postpartum hemorrhage, regardless of any other questions. It's always more than 500. Newborn who has asymmetrical moral reflex response. What are we thinking when we see asymmetric response? Hip dysplasia. Very good. Everybody should have gotten the clavicle. That's what you see. It's asymmetrical, right? So when you go like that, it's going to be asymmetrical. It's not going to move because that clavicle is broken. Neonate with meconium stained amniotic fluid needs care designed to especially monitor for what? Excellent. We always think about, why do we think about when we have meconium stained amniotic fluid? Somebody who answered that correctly. What do we think
That
about with
the
babies?
meconium
Aspiration.
went into their lungs.
Yep, it went into their lungs and then they're gonna have that meconium aspiration. All right, number 9. Woman at 38 weeks has painless bright red bleeding. This we should think about right away. Painless means what? What assessment should be avoided? Excellent. Somebody explained their answer for me.
Doesn't it
You're
mean
worried about
previa?
placenta previa.
Yep, and why are you not going to want to dilate their cervix anymore?
Their placenta is
Because you're
covering
gonna
their
put them into labor, maybe?
No,
Not labor, but
Tara, explain why you don't want it opened anymore.
The placenta is covering the cervix.
Yeah, it's
So
covering the cervix. So the more you open it, the more the placenta will be exposed. Alrighty. 29 weeks, what would be the most accurate determination of fetal position? All right, at 29 weeks, why would we not use Leopold's maneuver?
Too soon.
Why?
The baby is not supposed to be engaged yet, right? Like
Right, that's correct. What do we also know about an ultrasound versus Leopold's maneuver? Which one is safer?
the ultrasound.
Yeah, because you're not messing with anything at all. You're not pushing on the baby anywhere. You're not doing anything like that. And it's harmless to everyone involved. So just remember when you're looking at questions like that, you want to think about that. Patient has vaginal warmth, 90-cent contractions, fetal heart decels after gel. What's first? Oh, we're all over the board here. All right, 90-second contractions, fetal heart decels. What are we going to do? The first thing we do for decels on a fetal heart rate. Remember, we
Them
turn to the left. Then what else can we do to help them?
Apply oxygen.
Apply oxygen. What else can we do?
increase fluid.
Yep, you increase fluid. Those are the three things you do. Oxygen to the side and increase fluid. Why am I not going to notify the healthcare provider?
Because he's going to ask you if you've done anything first.
Yeah, and that's not our priority right then. Our priority is taking care of the mom and the baby. And what happens if we turn him to the side and then the baby's fine? Because it's cord compression. Right? So I want you always thinking about that. You don't always notify the healthcare provider. We're nurses, so we need to use our own judgment. New mom asked about swelling on her baby's head near the posterior fontanelle, crossing the suture line. What do we say? All right, so it's not a hematoma. How do we know the difference?
Caput crosses the suture line, and cephalehematomas do not.
Doesn't.
Excellent. So that's how you know right away. Let's see. What's our next question? After precipitous delivery, patient has continuous red blood trickling down, firm uterus, and normal vital signs. Okay, it should be not normal to have bright red blood trickling. Okay, it should come out and then stop and come out and then stop. Because remember, the uterus is contracting, so when it contracts, it squirts some blood out, and then it contracts again. Okay, why do you think laceration on the uterus? Somebody or on the cervix? Somebody who picked that. Why would that be your first thought when it was a precipitous delivery?
The labor happened too fast.
Yep, it happened too quick.
So it
So
causes
it happened
trauma.
too quick, and so it tore the cervix. Okay, and you should never have bright red blood trickling, because that means it's constantly coming out. Okay. 14, a patient's membranes rupture spontaneously. Fluid is greenish brown. What do we do? Good. Almost everybody got that one. Assess the fetal heart rate. Somebody likes contact the healthcare provider. There's nothing that is urgent that we need to contact them if it's meconium fluid. But why are we going to assess the fetal heart rate?
Yeah, to see if they have a respiration problem
Well, no, we're not going to know that because they're
or
still in
aspirin.
utero. They're not going to aspirate in utero, remember, because they don't have, their lungs don't work yet.
To see if they're in distress,
And why would we care?
because they've probably maybe swallowed some meconium.
No, remember, we're not worried about them swallowing meconium until they come out.
Wouldn't it be
Well,
more of like an infection?
Infection, yeah.
And
why do you think infection? What are we going to see when we have an infection?
your um your heart
You're
rate
gonna
is going to increase.
Right, but does it say anything about it increasing in this one?
No.
What do we know about meconium? When does that usually happen?
Well, this baby's probably past due, maybe.
Okay, if the baby's not past due, what causes meconium?
If the baby's in distress for some reason, it can cause them to have a bowel movement.
Correct. So if they're in distress or they're post states, either way, you got to assess that fetal heart rate. Usually it's a distress, if they're not post states, and post states is like 41 weeks plus. Okay. So you would anticipate having something with their heart rate. At 1 hour of age, the infant is jittery, tachypnic, and hypotonic. What should we know right away? Good. Why are we checking the blood sugar? These are three symptoms of low blood sugar right there. Alrighty. Somebody's getting oxytocin. What's our most important thing we have to obtain each time the rate is increased? We talked about this. Excellent. Why contraction pattern? Why do we have to look at that? Every time we increase Pitocin. Why do we have to look at the contraction pattern?
Isn't it to see if it's being effective or not?
No. What are we not going to do? What is going to tell us about a contraction pattern so we will not increase it?
If there's too many contractions
Too many
happening.
at once.
We don't want the
Fast.
mom's uterus to
Yep, you don't want the uterus to break. So you need at least some time in between contractions. You're not going to increase it if the contractions are already 2 minutes apart, right? Because you got to give mom a break. Alrighty. A 2 hour infant born by C-section by 39 weeks. Which is the highest priority? All right, someone who answered this, tell me why it's respiratory rate, nothing else.
when a baby's delivered C-section, they're not getting that
You're there. They're not getting what?
like they're not going through the birth canal, so their lungs aren't being like squished.
Yep. And in our first 24 hours, what should our blood sugar be?
Above 40.
Yep, 40 to 45 is the standard blood sugar within 24 hours. Then it should go up. But so this is normal. This is normal. And a faint heart murmur sometimes is normal if they haven't, if the pathways haven't closed exactly right yet, which should happen as soon as they're born, but sometimes doesn't. All right, currently 36 weeks, had a term infant and a pretermer and a miscarriage. What's their gravida? Good. Uh, aren't they 36? Had a term infant, preterm, and a miscarriage. So if you count on your fingers, had a 30 is 36 weeks, that's one pregnancy. Term infant is two pregnancies. Preterm infant is three, and a miscarriage is four. So it would be a gravida four, not a gravida three. What would be our para? Our gravida and para. Does anyone remember what para is?
Would it be 2?
Two. Good. Can you explain to us why?
Because she has 2 living children.
Yep. Two living children. Good. The client says, I thought I would be excited about having a baby, but sometimes I wish I wasn't. What are you going to say? Oh, perhaps you should discuss these feelings with your doctor, the poor lady. What about our therapeutic communication? Aren't we nurses? Isn't that our job to be therapeutic with our patients by saying, oh, you should take this up with the doctor? What is that doing to those feelings of that patient?
Dismissing them.
Completely dismissing them. Okay, so you sound pretty uncomfortable with these feelings you're having. So that's what kind of communication is that?
Therapeutic.
Yes, it's also open-ended, right? Open-ended communication. You guys have learned all about that. I know you have. All right. Pregnant client with brownish vaginal bleeding. Last menstrual period was 2.5 months ago. Vital signs are 98.7, heart rate is 70, blood pressure 130/80. What should I do? Excellent. We're going to check her values because what could be happening here?
Miscarriage.
Yeah, miscarriage. All right. Let's keep on going. Number 21 is a client receiving oxytocin to augment labor begins having tachycystole contractions and variables. What are we going to do? Remember tachycystole contractions. Interesting. Someone who picked the correct answer, turn off pit. Why?
Tachycystole could cause uterine rupture
Absolutely. So if it keeps going, why would I not decrease the rate?
because they still could remain tachycyst.
Right. They could still keep having those contractions back to back to back to back. If you
Yeah.
stop it and the Pitocin is the problem, which it usually is, then it will calm down those contractions, okay? 22 is 34-week multi comes to the clinic for an appointment. What findings should the nurse? Good. What's wrong with the fundal height of 30 centimeters?
It's more than 2.
Yep, it's plus or minus 2. Should be at 28 to 32, right? Given, I'm sorry, she should 34 week so plus 2 minus 2. So it would be 32 to 36, right? Okay, we are going to stop the Kahoot right there because we've covered most of the findings. Any questions on your HESI review? No? Okay, I am going to end our HESI review there. You guys have lots and lots of resources. So I need you to use those to study. You want to go over your calculations. That's very important. And does anyone have any questions for me at this point? Yes, Yolanda, what's up?
You asked if we want to go over the calculations. I said yes. Yes, that's fine.
Oh, no. What I said is you guys need to go over your math calculations.
Oh, okay. Yes.
I'm not going over calculations. You guys know where OB calculations is. There's
Okay.
videos to watch. There's practice questions. I'm not going over calculations because at this point you guys should be familiar with calculations. You guys all did pretty well on your OB calculation tests, so I'm not super worried about it. And if you didn't do well on your test and you met with me, you guys know why you didn't do well. So, and most of those students are not calculation problems.
Okay.
Any other questions, concerns? Okay, we have HESI next week, and then we will have class the following week. It's up to you guys if you want to do it during class time the following week, or if you want to schedule certain times with me. I can send out a calendar for Monday and Tuesday of that week, which will be, let's see here. Let's look at a calendar. It'll be the 25th is our class. And so the 23rd and 24th, I can send out a schedule, or you guys can meet me on the 25th. Let's see by a raise of hands. Would you like to schedule your own appointments? 23rd and 24th? Raise your hand now. All right, I only have 1, 2, 3. All right, so you got 4. So you guys just want to schedule the class as a whole? Everyone's going to have to meet with me individually. That's why making individual appointments is kind of better because you're going to be sitting there waiting to meet with me. But I need to meet with you guys before before that Wednesday.
I mean, I work all day on Tuesday and we have class on Monday. So I don't know.
Okay. All right, then you guys are going to be spending a lot of time on week 12 meeting with me, but then everybody will meet as a class then.
What is the meeting for?
Everyone needs to meet with the professor before the semester's over.
Okay.
Okay, so we'll just meet as a class then on the 25th.
If it's only one person that can't do an individual appointment, can that one person meet with you on Wednesday and we meet with you Monday and Tuesday?
Yeah, but it doesn't seem like I'm getting an overwhelming anything. People aren't really responding. They're just sitting there. So if you guys want it, you have to let me know loud and clear. But I'm happy to meet with the one person who works and has school on Tuesdays.
I have to meet.
I mean, you could
class
send
time.
out times, I guess. Yeah.
All right, well, let me think about it. I'll let you guys know then, because I'm not getting much out of you guys tonight. So let me think about it, and I'll figure out a plan.
Can I meet with you after class today for a
Yep.
second?
All righty, take care,
Oh, I
everybody. Good
am too.
night.
I also want to know, when do you want to meet with me as well?